A very good afternoon to everyone and welcome all of you to the 53rd live webinar on orthopedic principles. Today we have Professor Bijayendra Singh back with us. He's from Kent, United Kingdom, and he's also associated to the Canterbury Christchurch University as professor. Over to you, Professor Singh.
Thank you, Hitesh. It's good to be back. Today, I'm going to discuss a few things on the rotator cuff tears and how this will present or come at the fellowship exams. So with rotator cuff tears, you could get it in any scenarios, really. You could get it as an intermediate case for 15 minutes where you'd have to take the history exam in and make a management plan. It could be on the adult pathology Viva table as well. And occasionally it may come as a short case. So and I suspect that you will probably get at some point in time on your journey for the fellowship exam. So it's quite vital that you are aware of the condition as well as the options. So in general, I mean, I'm not going to talk to you about the basics of the rotator cuff. I expect everybody to know about the basics, but the rotator cuff essentially is a group of 4 muscles. And when the term rotator cuff is used in normal terminology, most of the time we think about the supraspinatus and the infraspinatus. Yes, subscapularis and teres minor are also part of the cuff, but when they are involved, they are spoken as those individual muscles. So in general, I would suggest that if there is just a talk about rotator cuff, we're usually talking about the supraspinatus and infraspinatus. Now, the supraspinatus is the more, or both of them are important. They have different functions. The supraspinatus inserts on the anterior superior aspect of the greater tuberosity with a medial lateral width at insertion of about 12.5 millimeters. This infraspinatus, in fact, has a slightly wider wider insertion than the supraspinatus, but the supraspinatus is the one that is more commonly torn and gets affected. The subscapularis inserts on a still larger footprint and is attached anteriorly. The teres minor is not that commonly affected. There is a small gap between the articular cartilage and the medial footprint, and the anteroposterior diameter of the dimension of the footprint is 20 millimeters. So that's what we're talking about when we do a repair of these tendons. The rotator cuff, when it attaches, it's in 5 different layers. And in technical, I mean, these is histology, but in technical terms, we talk about the articular surface tear as well as the bursal side tears. So the 5 different layers, the most superficial layer is towards the bursal side, which is composed of fibers from the coracohumeral ligament and extends posteriorly and obliquely. The second layer is composed of densely packed fibers. Layer 3 is of loosely organized bundles of collagen. And layer 4 is mainly connective tissues, and layer 5, the deepest part, is your the shoulder capsule. Now, the blood supply to this is from all aspects, so both bursal side and articular surface side. So the subscapularis, the suprascapular, and the humeral circumflex arteries supply them, and they're usually present in the superficial layers. The bursal side is more vascular, and the articular side is less vascular. Hence, the bursal side tendon tears tend to respond better than to just the partial articular surface tear or the pasta tears. So why do cuff tears happen? We don't exactly know the reasons, but extrinsic factors, repetitive use is probably the most common, and that's why we see the chronic degenerate tendon tears more often than an acute tears. although in young adults you can get acute tears, and that's a completely different presentation and different kettle of fish, so to say. They may have some instability related issues, generally with internal impingement types. The other extrinsic factors are acromial spurs, coracoacromial ligament, osteophyte from the AC joint. These are the three main factors. Regarding the acromial spurs, there's still no agreement whether it is an effect or the cause of the impingement and cuff tears. There's some thoughts about the intrinsic factors where the blood supply becomes tenuous to the rotator cuff, which increases the tear. And hence some people believe that steroids should not be used in early stages of tendinopathy, rotator cuff tendinopathy, as this aggravates and makes the tear worse. But there is no studies to confirm that doing steroid injection actually makes a clinical difference. Yes, on microvascular levels, there is a difference for sure. So how do you classify tears? You can do partial or full thickness tears. Element classified the partial thickness tears, one less than 3 millimeters or about 25% thickness. 2 is 3 to 6 millimeters and 25 to 50% tears. And 3 is more than 6 millimeters or more than half. So this comes useful if you're dealing with a patient who has got partial thickness tears. If it is less than 25%, then most of us would leave it. If it is between 25 and 50%, then it would depend on the extent of the tear and which side the tear is. Again, in vast majority of them, you could leave it. If it is more than 50%, then the options differ slightly in the sense that some group believe that this tear should be completed and repaired. Some group do it in situ repair, especially of the articular surface tear. I personally come from the group where I believe that you should make the tear complete and then treat it like a full thickness tear. You can describe according to the location, as I just said. So you can have an articular sided tear or a bursal side tear. Intratendinous tear is a new terminology which has been picked up, especially since the MRI has started becoming more regular in use. And this just suggests degenerative changes rather than changing any surgical treatment for the patient. The Pate classification describes as to the extent of the retraction. And this is one of the reasons why I generally prefer MRI over ultrasound in cuff tears. As you can see the level of retraction, and you can explain this to the patient, and also helps you make a plan whether this tendon is going to be repairable or not. So stage 1 is essentially where the tendon hasn't retracted at all. Stage 2, when it's moved slightly medially, but in vast majority of the cases, one should be able to do repair fairly straightforward. When it is at glenoid level or thereabouts, this is usually associated with other factors, like it's usually a big tear or a large tear or a massive tear. Often the tear is stiff, and quite regularly the muscle, there is a fatty degeneration and atrophy. So that all combines together makes that kind of repair difficult, and hence you can then explain to the patient what your plans are and how you're going to manage it. So I just mentioned the MRI scan. I will just have a few slides on the MR. The MRI is usually performed in 3 planes. Hello?
Bijay, are we on the first slide itself?
Oh, it's not moving, is it?
No, it isn't.
Oh my God.
I was a bit surprised. I thought you were talking, just continuing to speak through the slides.
Okay, 1 second. I don't know why does it say, okay, you are screen sharing. So shall I restart the whole thing again?
Oh, we have gone quite loud, is it?
Okay. So we can start from.
Yeah, pate is fine. Yeah, that's also, we can just have a recap, not an issue.
Okay. So let's go to the MR. Now, let me know.
Or you can change it. Yeah, now it's showing MRI.
But you see, it's saying sharing is paused. Bring your shared window to the front. Can you see anything, or is it just stuck on MRI?
You can, yeah, it's on the MRI. You can go to the previous version. I mean, just before going full screen. Yeah, I think you can go from here. That's better.
But this is not full screen, is it?
That's okay. That's okay.
That's better.
Yeah.
Okay, 1 second. Let me make this as big as I can. Okay. So now, before you start recording again, just check that it is working okay. 1 second. Yeah, okay. Yeah. So start again. Hitesh?
Yeah, you're fine.
Okay. So,
Anti-classification, if you don't mind.
okay. Hattie classification. That one, yeah?
Yeah.
Okay. So, sorry, we were discussing about the classification for the rotator cuff tears. And as I was alluding, so this is the classification which comes in quite handy for clinical making decisions, because this helps me advise patients about the tear itself and what to expect. So stage 1 is when the stump is near the bone insertion, and this is most commonly seen with a small tear or acute tears as well, and this is a pretty straightforward and easy repair. Stage 2 is where there is some retraction up to the level of the humeral head, often up to the mid-humeral head. And again, these are pretty straightforward ones to repair. The stage 3 is where the end of the cuff is at the level of the glenoid or more proximal. And this usually suggests that the tear is quite large or massive, is likely to be stiff, and it's also likely to have other changes, as in wasting and fatty degeneration within the rotator cuff, making the tear more difficult or often not possible. And hence you can advise the patient accordingly. So the MRI is usually done in 3 different planes relative to the glenohumeral joints, and these are the 3 sequences that are typically done. One is the coronal oblique, which helps you decide the retraction on the Pater classification. The sagittal oblique tells you about the fatty infiltration and the muscle wasting, and the axial seat is used for looking at subscapularis as well as the extent of the tear. So these are a couple of slices on the MR of the coronal oblique, and you can see here that this one shows a partial thickness tear, whilst this one shows a full thickness tear, and it helps you look at both the supraspinatus and the infraspinatus, the subacromial space, and the labrum issues, as well as biceps tendon. So this is a short video on the MRI, going from the front to the back, and you can see that that's the tear starting to come up there, and you can see it's a full thickness tear. So this is like a pate grade 1, where you can see this is the supraspinatus tendon, muscle belly forming a tendon, and it's tore. That white is the fluid that is present, but it's more or less where it should be. And you can see it's fairly large tear, And this is now going into the infraspinatus territory, where there is some partial thickness tear, but it's not involved significantly. So that way you can advise the patient about the management. The MR sagittal oblique helps you decide, look at the muscle atrophy. So as you can see here, this is the Guattelier classification. And generally you would expect the supraspinatus to incorporate almost the whole of the supraspinatus fossa. But here you can see it's below that line, suggestive of some fatty infiltration and atrophy. The axial scans are useful to look at the biceps tendon, which is particularly important if, well, it's important in all patients, particularly if you've got a traumatic cuff tear, as often these are fairly massive tears. Look at the glenoid, the labrum, the subscapularis. As you can see here, this is a patient where the biceps tendon has moved from its groove and is lying here medially. And this often is associated with a subscapularis tear. And at the bottom one, this is from an instability patient, where you can see there is labrum disruption as well as a small loose body in the posterior aspect. So let's look at this axial CT MRI scan. So in the axial MR, you can also look at the AC joint. So this is now just coming up to the supraspinatus tendon and the humeral head and the glenoid coming in. And if I pause it there, you can see this is the subscapularis, a fluid on there. And again, you can see that this is the biceps tendon, that's the subscapularis, and it should normally be seen quite thick band, robust, almost like you would see an ACL, intact ACL. It's fairly firm, thick structure that cannot be missed, and you can see the biceps tendon out of its groove right the way. So this patient has got the subscapularis tear as well as the supraspinatus. Now, briefly about the ultrasound. Yes, the ultrasound use is increasing. It's a very good handy tool. My personal view is that it's best used by the person who is interpreting the data. If, as a surgeon, I think it's best used in your own hands, because otherwise you're relying on secondhand information. The pictures are not dynamic, and you're relying on the interpretation of the radiologist. But if you're doing it, then there needs to be a protocol of how you're going to look at these. So starting from the biceps and the subscapularis at the front, then the supraspinatus, then the subacromial bursa, and then round the back. And you need to understand what the anatomy looks like. And one of the main reasons why the ultrasound is so much operator dependent, because if you look at these two images, this is of the same patient, and what the difference is, the angle at which this probe is held is different. So here you can see which is held perpendicular, and you can see the biceps tendon in there. In this picture, the probe has been angled slightly so that this biceps appears to be empty. So if somebody was looking at the bottom picture, you would think that the biceps is missing, but in fact, the biceps is still very much there. So that's the downside of the ultrasound tendon. So these are just the three sections of different MR. So on the left is your normal looking rotator cuff tendon. The supraspinatus here, there is a partial articular surface tear. And on this one, you can see there is a full thickness tear. So this is an example of a patient who had a fall whilst running, and he fell with an abducted arm. And you would get this on your Viva table with these pictures and that history. So essentially, you've got to evaluate both the planes and see where the problem is. So if we start with this top right-hand corner MR, so this is a coronal MR T2 most likely to be, which is showing the supraspinatus muscle belly and forming a tendon. And as it comes to its insertion, I can see there is a gap there, and which is also seen on the further slide, further image further down. There's a fair amount of fluid all around. The glenoid and the humeral cartilage looks fairly normal. On the other pictures, this looks like a T1 image, which shows on the top one, I can see the biceps tendon has moved out of its groove, and the subscapularis also looks to be torn, which is seen even on the bottom picture. So looking at this, my diagnosis would most likely to be that this patient has got a large or a massive rotator cuff tear. And I would like to examine and assess the patient, take a good history, and then make a management plan, which is most likely going to require a surgical repair. Now, the question is whether these rotator cuff needs to be operated upon. So what's the natural history? This could be a potential question. So this is one of the studies looking at natural history of non-operative treatment of symptomatic rotator cuff tear. Now, it's quite important to differentiate between a symptomatic cuff tear and an asymptomatic cuff tear. So often people will bant around the asymptomatic cuff tear, but we are not advising treatment for asymptomatic cuff tears. So this study looked at patients under the age of 60 who had 5 millimeters or bigger tear on an ultrasound. They followed up for at least 2 years or longer, and the ultrasonography was done by the same sonographer. They had 51 out of the 61 patients return. They showed about 50% increase in size, and nearly similar numbers did not show any change. And also a quarter of them found to have new tears. It's interesting to see that they did not find any correlation between the change size in the tear size change related to patient age, previous injury, or the size of the tear. But importantly, they found that if the patient's tear size increases, so does the symptoms increase as well, which is what you can reassure a patient with a small tear that if their symptom starts to get worse, then it is suggestive that their tear is becoming bigger and they may need to take advice. Now, when you come to cuff repairs, there are certain factors which are modifiable and certain factors which are unmodifiable. So what you can modify is the type of repair you do and the technique of repair, types of sutures, anchors, whether you do an open or arthroscopic, and the type of rehabilitation that one uses. Now, in most places, these days, the cuff repairs are done arthroscopic. The advantages of open versus arthroscopic is only seen in the early stages. Most studies will quote outcomes at 1 year, and yes, at 1 year there is no difference, but certainly in the first 4 to 6 weeks, the level of pain relief, complications, time off work, and patient comfort is much better in the arthroscopic one. The certain things that is unmodifiable, which is the age, the type and age of the patient, the type and size of tear, the retraction, and the fatty infiltration, and the quality of bone. What are we trying to achieve by doing a cuff repair? We're trying to provide a tendon to bone healing with the idea of providing pain relief, improve function and strength, and hopefully reduce progression to a cuff tear arthropathy. So what does a successful repair require? It requires adequate decompression, restoration of footprint, providing good compression of the tendon on the footprint, and minimize tendon-bone interface movements in the early stages. These are the few steps that you need to be aware of when managing a patient with a cuff tear. Some of these are technical, which may not be inquired during the exams, but as a general principle in managing cuff tear, positioning of the patient, fluid management, portals, instrumentation, biomechanics, the recognition of tear pattern, the approach, how you're going to repair it, whether a single or a double row, those are factors that one may need to consider. Sorry. The key thing is work to a system when it comes to practical uses, although again, not so much of a fellowship related, but more practical, whether you tie knots, passing sutures, repair type, that's what you need to familiarize with. So there's a couple of short videos on single row and double row cuff repairs. So single row is where you put the stitches in on one only single row and attach it to the bone. I use a knotless system, so this is what the technique is. So here you pass the sutures in with any suture passer that you use. I generally tend to use a mattress type of stitch, as it's shown to provide better compression and less point loading of the tendon. Often I would pass a ripstop suture that would go across and under the mattress. Once you've done that, you identify your spot where you're going to insert the anchor. This is a punch to make the pilot hole. And then the anchor going in, and you can see the tendon has been brought in quite nicely. Now, there are different techniques that I use, and for the fellowship exams, I would suggest to you talk about technique that you are familiar with or you have seen your bosses use it, as it's easy to answer any questions. Or especially if your boss is using something unusual, you won't be criticized for that. This is the technique for the double row. As you can see here, this is a much bigger tear. That's the edge of the cuff. This is the articular surface, and this is the footprint. So the first step is to prepare using the burr, and this shows nicely the size of the tear. And what I'm doing is using it on reverse to just decorticate the bone, then checking the repairability, and you can see it's quite a mobile tear and comes and sits nicely. Identifying my medial row anchors with a needle first before I make another portal. The first medial row anchor going in now. So again, I use a knotless system, and the advantage of this system is that it locks the medial row sutures in, so you don't have to tie the knots on it. Now, these videos are available on my website, so I'm going to skip it through for time purposes. So those are the two medial row anchors going in. And then you pass your sutures through the rotator cuff. Okay. Now, question is why should one be using a single row or a double row? It's basically the strength of the repair. The single row provides about 220 newtons of pull-out strength. The double row increases that by about 50%, and the suture bridge, wherein you crisscross the stitches, provides a higher pull-out strength. Now, it's important to remember that a few basic studies to look at what the strength in the rotator cuff repair needs to be is actually quite low. So the pull-out strength needs to be about 180 newtons. So what it suggests is that even a single row repair is probably strong enough to provide the healing. But more and more studies, as I will show, are coming up to show that the double row is better. Now, the clinical outcomes of this use of single or double row shows that there is not a significant difference in the most of these patients. But what we know that is certainly in the larger size of cuff tears, the double row has shown lesser amount of re-tear rates with a double row repair, and hence that's what people are advising. What about the rehabilitation? How does it affect the eventual outcomes? So this study looked at 4 different aspects of early versus delayed rehabilitation. What they found was that a lot of studies show that range of movement is better if you get mobilization sooner, especially the elevation is better in early stages. And again, like with lots of range of movement things in orthopedics, pre-op range of movement is shown to be the most important factor to regain the movements. And again, there is no difference at 1 year. There's no difference in the level of pain in early or late mobilization group. Muscle strength, there is no difference between early and late, but it still stays lower than the other side. And re-tear rates, these are re-tear rates on MRI scan, and this is variable and up to more than 90%. But functionally, there is no difference between so in fact, I now mobilize most of my patients at 2 weeks. So to conclude, the key to success is to pick a winner, have a good anesthesia, tension-free reduction and repair, need to do a thorough birsectomy for visualization, work to a system. There's variety of equipment is invaluable. And in my own practice, for small tears, I would do a single row mattress repair, and for a larger tear, double row suture bridge type of technique. Thank you.
Vijay, thank you for that presentation, and it was very nice listening to you. There have been a couple of queries.
Yeah.
Both are related to the 2 trials. One is the U-cuff trial by Carr, which looked at arthroscopic versus open and said that the difference is not major. What do you think about it?
Yeah, so as I said, it's a lot of these studies actually focus on the 6 months or a year down the line. So yes, you know, whether you do it open or arthroscopic, 1 year outcomes are no difference. And I don't think any shoulder surgeon will deny that fact, that it's the initial part, the post-op recovery, the inpatient stay, and also the risk of infection and wound problems. And also, I personally find that, you know, with the open repair, your visualization is fairly limited. With the arthroscopy, you get to see it more often. The other thing which, I mean, unless you are a surgeon who still does a shoulder arthroscopy, does the decompression arthroscopy, and then does the repair open, that's one group, but that's okay. But if you're just doing open cuff repairs and not doing the shoulder arthroscopy to begin with, you are likely to miss out on a lot of intra-articular pathology. So simple thing like a partial biceps tear, or if there is a loose body or something like that. So that's my take on the open versus arthroscopic repair. For people who are starting off, have got equipment issues, yes, you can learn to do it open and then move on to arthroscopic repair.
Thank you, Bijay. The other one is regarding the other very popular trial, the Seesaw trial, which was published in Lancet, again from the Oxford.
Yes.
And they looked and they say that there is the role for a subacromial decompression is like minimal or not there at all. What do you think?
Okay. So the Seesaw, I mean, I was one of the contributing surgeons to the Seesaw trials. Now, what people actually forget is that all the patients, certainly in the UK and certainly in my practice, that who come to decompression have actually exhausted all the non-operative means following surgery, following the shoulder pain. The other important bit, because when did this come? This came in
2014 Lancet.
Was it 2014 Lancet? Yeah, okay.
Yeah.
And no, I thought the Seesaw was a bit later.
No, Seesaw was in 14 and 2017 was the UCAF.
Okay. And basically what happened was we all looked at and also there was a big article in the BMJ saying that all this shoulder surgery is not good. And we all actually, as shoulder surgeons, we looked at our own practice, and what I found in my practice, because they don't classify as surgery for what? They put it all under shoulder pain surgery. Yeah. So the BMJ headline was surgery for shoulder pain is not good, or something along those lines. And in fact, in my practice, only 15% of my shoulder arthroscopies are actually pure decompressions. So 85% of my patients have either got a biceps problem or a labral problem or a cuff tear, and along with that, an ACJ pain. And all of them, even the 15% who underwent a simple decompression, have had the previous non-operative treatment. And I haven't done PROMs on my patients, but vast majority of them have got no post-op, they're quite happy after the surgery.
Okay, thanks, Bijay. What is your approach to a large tear? For example, if there's a defect, how do you bridge that? Do you use a fascia or use a...
So the options obviously depends, if this is a fellowship exam question, the option depends on the age of the patient, the type of tear, what their expectations are, and what their shoulder function is like. Now, most of the treatment, except for a shoulder replacement, is good if the patient does not have a pseudoparalytic arm. So they are good for pain relief, whatever you do, except for tendon transfers, I guess, which will help with the movement as well. So whether you do a superior capsular reconstruction type of procedure with whatever, whether you use a allograft or you use an autograft, they are all designed mainly to help with the pain. I personally use the balloon interposition arthroplasty for two reasons. One is A, it's arthroscopic. B, is technically easier to do, and C, you're not burning any bridges and the complications are fairly minimal. There's no more complication than any other shoulder arthroscopy. With the superior capsular reconstruction, it is technically a very demanding procedure. It's fairly expensive because even at the minimum, you're looking at 4 suture anchors at the least. and also the outcomes haven't yet, I mean, there are studies coming out now, but it's not universally that everybody has had a good outcome. So that is second option. In some cases, the one that you mentioned about the patch. So essentially the patch was originally described as a reinforcement mesh rather than a bridging type of gap. And I know there's a few studies, actually, one big study from Leicester where they used it as a bridging graft, and it has shown good outcomes. I personally don't have any experience with using those patch grafts. And of course, if the patient has got pseudoparalysis, then the only realistic option, apart from physio and pain relief, is a reverse shoulder arthroplasty.
Okay, Vijay. And what is the principle behind the balloon interposition that you described?
So the balloon interposition arthroplasty, as we all know and as we all see, there's lots of patients that we see who have got a big cuff tear, and they still function very well. So they can use their arm. Yes, they are weak, but they can still move their arm. And that is because their deltoid is functioning well. And the idea of using the balloon interposition is that it sort of tenses the deltoid. So it puts the deltoid at an optimum tension and allows the deltoid to take over that function. Because remember, the balloon is made out of PLLA, as in the same material as Weichel sutures. And that gets absorbed in 6 months to 12 months maximum. And so that effect is no longer there. But hopefully by that time, the deltoid has been retrained and has started to take the function over. And I think, what's his name, George Arthwell, published some study, biomechanical study, to show that effect.
Yeah, George Arthwell from Canada, right?
Yes, that's correct, yeah.
Okay. And do you keep it in the subacromial space? Where do you leave the balloon there? PLLA.
So it stays in the subacromial space. So basically the steps would be that you do a bursectomy. You don't do the bony acromioplasty because you don't want any sharp edges. And then the balloon comes up rolled up, and it's in, as you push the fluid in, it unfolds and just sits on top of the subacromial bursa or the humeral head.
Okay, Bijay, I think that's all the questions that we have, and we have done, I mean, even in previous lectures, I think we have touched a bit about the cuff, and I think this has been comprehensive and covered the entire aspect. And
thank you.
Since
So
there are
just
questions, yeah, we can wind up this session.
Just one thing, that on the YouTube, I have got a video channel.
Yeah, please.
So it's called Kent Orthopaedic Practice. So if anybody is interested to have a look at them,
sure,
then they can find the videos. And I think I've given you my email address. If anybody has any queries, I'm more than happy to answer.
Thank you, Bijay. Thank you, Bijay, once again for sparing your valuable time.
Thank you, Hitesh. I must appreciate, you work so hard for all of this, it's just amazing.
Thank you once again, Bijay,
yeah.
for the very kind words. And
no problem. Yeah.
from
Thank you.
side.
Thank you. Catch up soon.